Welcome to today's webinar. My name is Russ Rowan. I'm the Director of Marketing for Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we'd love to hear from you and be able to answer any questions that you may have. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time. We'll try to get them answered during the webinar. Once the webinar is complete, you will receive a feedback survey in your email. Once you complete that survey, your CE certificate will be emailed to you. So keep an eye out for that email because that's important for us to receive so we can then send you your CE certificate. So I'd like to introduce today's presenter. Dr. Melle Vroom received his DDS from the Academic Center for Dentistry in Amsterdam in 1994. He also attended their Masters of Science program in Periodontology from 1995 to 1998. Since then, he has maintained a private practice in the Netherlands, which is limited to periodontics and implantology. Dr. Vroom is a national and international speaker on d-PTFE membranes. He's spoken at the Osteogenics Symposium, AAP, and the Osteology Symposium, just to name a few. He also gives multiple hands-on courses throughout the year. In fact, we were recently fortunate enough to have Dr. Vroom teach a hands-on workshop that Osteogenics hosted in New Jersey this past summer. The workshop was met with great feedback, and everybody that attended really enjoyed it and got a lot out of it. Dr. Vroom did a webinar for Osteogenics when we first started doing webinars back in June of 2023. And since we've posted that webinar on YouTube, it's received over 4,000 views. So we felt it was time, Osteogenics and Dr. Vroom both felt it was time for a follow-up. And so we're really excited to have Dr. Vroom present to us today. And with that, I will turn it over to him. Thanks, Dr. Vroom.
Thank you, Russ. If we think about implant congresses and implant meetings, and you see through the years at these programs, you see, of course, that new techniques are introduced about GBR or implant placement. And also, proven GBR concepts are discussed and backed up with more literature. But if you look more closely at those programs, I was a little bit surprised because healing complications, or moreover, importantly, how to deal with them, there's hardly any attention to that fact. Well, of course, it's crucial information for all around the world who are treating patients with GBR in daily practice. So today, we are going to talk about healing complications and how to manage them in GBR procedures. And of course, today we're going to discuss GBR procedures when we apply dense d-PTFE membranes. Russ already showed it in the introduction, my background, or illustrated. I want to illustrate it. This is the practice I work in the north of the Netherlands. I work together with my colleague Lodewijk Grundeman, seen on the right. And today I'm going to show our clinical cases, our opinions, and also ideas which we came up through time, because we have been using this membrane for more than 15 years. And we're thinking over what could we improve? What should we do if there was a complication? But first, if I use these dense PTFE membranes through the years, I start to realize that it brings so much joy to your practice. For example, here on the left, we see a very thin ridge, and we're gonna apply then bone graft, the dense PTFE titanium reinforced membrane, and we close the tissues. And we could close the tissues, kept them closed, the healing was uneventually, and after 6 months we opening up. And we see the membrane, we take it out, and we could place the implants. That is it's a lovely feeling to see in everyday practice. Or another case which brings also a lot of joy, a very thin ridge on the left. We apply the bone graft and the dense PTFE titanium reinforced membrane. we close the tissues, and the healing is done eventually. And then we open up after 6 to 7 months. We see the membrane, we take it out, and with the periodontal probe, you could appreciate the massive increase we got. Or another case like this, where we see if we open up the tissues, that we see that the ridge on the vestibular side is thin, but also on the lingual. So we have to build up on both sides. So we apply the bone graft, we apply the titanium reinforced dense PTFE membrane, and after 6 months, we opening up and we see that on the both sides we could increase. By the way, this case really shows very nicely that the membrane dictates where the bone is going to be. You shape it in the right size and in the shape you want, and you're going to get it. And that's the great joy of this membrane. And I started with implant congresses and meetings. And of course, like these cases, they show nice cases. But hardly the what if question is asked. What if complications do occur? And how should we or can we manage them? What have we learned through the years? First of all, let's look at complications in guided bone regenerations in general. I think we look at them independently of which membrane you're using, we can see that we can have, let me see, we can have three kinds of complications. An exposure, so a flap dehiscence, we see the membrane is exposed or the bone graft. The formation of a fistula or swelling and purulent exudate. And we also can have a combination of those three, but also at different time points. Early, when just the GBR has been performed, or maybe after 2 or 3 months, which I will show later on in case. If we look at exposures in GBR, I noticed that there's a certain general view, like, well, when you use non-resorbable, they are more prone to exposures. Well, if you use resorbable, you don't easily get that. And also, this is in a way fed by, for example, a consensus report, the 15th European workshop from some years ago, where they state that the non-resorbable have an increased frequency of membrane exposure rate. But is that really true? If we look, there we go. If we look at some studies and they compare the older expanded PTFE, it's the first version of the PTFE versus collagen, then he shows in a study that 14% is for the non-resorbable and 30% for the collagen. So it could be the other way around. We also have, for example, the 3-month study from a long time ago show for both very high exposure rates. And Moses' study compares it also with a resorbable cross-linked and sees nearly the same figures. And if we look at the Friedman study from some time ago, I think it really illustrates that through time we have improved our surgical skills, also by more techniques which became available. And it's interesting, of course, that we can state that surgical skills do matter. I mean, if we look at research from dental surgeons like Urban or Ronda, they report in studies exposure rates of 0. But what if? What if an exposure of this non-resorbable membrane, the first ones, the early ones, the expanded, happened? Well, various authors report bone frill from 0 up to 73, stating that it's suboptimal or a complete failure. So when it was an exposure with this early ePTFE, it has a strong negative influence on the bone formation. Okay, that's true. But in the meantime, a lot of people start using then the collagen, the resorbable ones. And there was a kind of general view that if you get an exposure with a resorbable, it will heal by secondary nature, healing, I mean. So what happens to the exposed bone? Well, the bone underneath is still considerably reduced, as shown in the Moses study of 2005. And don't forget, if a collagen membrane gets exposed, research by Klinger shows that in a human study, that after 10 days, 1/3 to 2/3 is already a disintegration of the original form. So you're not in control of your barrier function anymore. And the following study really illustrates what happens with the first generation, the expanded PTFE, when it became exposed. Very nice study by Simeon, where he treats in group A patients conservatively, meaning he extracts a tooth, let the tissues heal, and then after 30, 40 days, place an implant, places the PTFE membrane with primary closure, and after a second phase, after 3 months of healing, looks at the regeneration. While group B is more a test group. So he extracts a tooth, placed the implant immediately with the PTFE membrane, so there was an exposure. And they took out the membrane after 30 to 45 days, and then let the tissues heal, and then did a second phase surgery. But more interestingly, they also looked at membrane characteristics and the amount of regenerated bone. So the mean regeneration, if you do it in a conservative way, so no exposure, they got a lot of regeneration, 96%. While in the group where it was exposed, it was 41. And they report large amounts of bacteria on both sides in this group B. So it really shows that this early ePTFE version was permeable for bacteria. They could migrate through. And they also state that exposure is a complication which really can reduce your amount of regeneration. And with those complications, of course, it does also matter that there is a learning curve. That's relevant. And that's why I like this statement of Hammerle and Jung from some time ago that GBR is difficult and skills and experience are a crucial factor to get really nice results. So if needed, get well trained, go to hands-on courses, learn the details, and learn how to deal with this soft tissue. So complications did occur with the early PTFE membranes, the ePTFE ones, and Fontana proposed a clinical classification to deal with them, but also for easier identification. And we see that, for example, a management example is that if there's a small exposure, less than 3 millimeters or up to 3 millimeters, he cuts away the exposed part. That's what they proposed. While if it was a larger, more than 3 millimeters, they took it out immediately. And it was at congresses and meetings more than 10 years ago that, my colleague Loda Grundemann and myself, we started realizing that people were applying this classification, these management steps, but also used them on dense PTFE membranes. And we thought this is not applicable for the dense PTFE. So without people really sometimes realizing the evolution of the membranes, I try to go to the next one. Let's see if that's possible. It's the evolution of the PTFE membranes went on, And in a way, it looks for, it went on in the background from the early e-PTFE to 1994, TEFGen, and then in 1997, the dense PTFE cytoplast membrane, with 1 year later, the titanium reinforced version. The main advantage of this dense PTFE cytoplast membrane is that it's opposite to the expanded first ones, it's non-permeable to bacteria. So there's a distinctive difference between these two membranes, and that results in a clinical handling which is different when exposures occur. We also noticed that colleagues at congresses said, well, if there's an exposure with a dense PTFE, take it out immediately or cut away a part, which is shown at some clinical videos. And we thought it was totally wrong. We thought it's time for another classification, which is specifically for dense PTFE membranes. Of course, this is applicable for dense PTFE non-perforated membranes. And we submitted it in 2017. And the editors were really positive. They said, well, this is a good idea, and but let your experience grow with it and send it in a few years later. So we improved this clinical classifications, and then also we got in contact with Pierre Gallo, who is seen here. We got in contact with him on the Osteogenics Global Symposium in 2016, where he gave a very honest presentation about the learning curve and also exposures. And Dr. Gallo already published another clinical classification, but when we got in contact with him and told him what our classification was different, he says, it all makes sense, your rationale. I like to join in. And to be totally clear, our aim with this article is to help colleagues around the world take the right measures so that you will end up with nice results. The article was published in the International Journal of Periodontics and Restorative Dentistry 2 years ago, and it drew attention. There was interest, for example, in lively discussion on Instagram of the Academy of Osseointegration monthly review group. And recently, in the period 2000, Professor Donas describes in a review the classification quite in detail. But maybe you can say for yourself, well, there are already clinical classifications published in articles or in well-known textbooks. But there is a distinctive difference with these other classifications with which I'm going to explain in a few minutes. But first, I like to go back for the rationale behind our clinical classification. We first move to a very impressive study by Professor Schenk, a classical one, which describes GBR. It's an animal experiment where they opening up the tissues in animals, create surgical defects, and they close the tissues and then let it heal. And in the control group, they apply no membrane, while in the control, they apply a membrane which is titanium reinforced or not. And of course, they report about the bone growth you can get, also as published by Dalin earlier. But interestingly, he describes the phases which goes on underneath this membrane with histological slides. From first blood clot, to then the second woven bone, primary spongiosa, and then to lamellar bone and bone remodeling and formation of osteons. And it's this histological documentation where Professor Lang, in the textbook Clinical Periodontology and Implant Dentistry, refers to. He refers that documentation confirms that the bone regeneration in membrane-protected defects follows closely the pattern of normal intermembranous bone growth. in extraction sites. So you get a kind of similarity, like it's a covered extraction socket, and underneath there's a similar sequence of maturation steps. And then it becomes interesting even more because this shows the image of a covered extraction socket, the cytoplast d-PTFE rich preservation technique, more over than 20 years ago described by Dr. Barry Barty. Fascinating technique, which in daily practice is giving wonderful results. A technique, if you ask me, which didn't get the appreciation at various congresses, which it really deserves. But what about this technique? Well, here we see the drawing. So a tooth is taken out and the extraction socket is covered with a membrane which is partly left exposed, which of course is possible because bacteria can't migrate through. And during lectures or courses we give, we notice that sometimes participants easily mix up indications. So that's why we introduced on the left side of your screen the closed GBR, we call it, meaning that the tooth is already taken out some time before. We open up the tissue, we apply the bone graft and the d-PTFE membrane, and we close the tissues again. So closed GBR. Well, on the right, you see the open between quotation mark, GBR, meaning you take out the tooth, you cover the extraction socket with this membrane, and leave it partly exposed. If you start using this technique, it's in the beginning a little bit exciting because you think, well, will this go in the right way? But it will, as I will show you with the next case to illustrate this technique. It's a patient with a first molar with deep pockets and also a lot of bone loss, as you can see on the cone beam scan, and a resorption of the root. So we take out this molar very gently and we apply the bone graft and we apply a titanium reinforced 12 by 30 ANL. And we always use them. You maybe ask why. Well, this is our favorite membrane. And that's because some time ago we asked Osteogenics to produce this site. And they said, well, this is a right idea. So that's why the 12 by 30 titanium reinforced is also a very useful size when you, for example, in a closed GBR want to restore a one-tooth site. It's perfect for it. But let's get back to our case. Here we see the same case. After 4 weeks, we take out the membrane and then we see the osteoid matrix has formed and we let it heal by secondary healing. And then 5 months after extraction, we see a nice increase of keratinized tissue and we see the bone has been restored. The referring dentist makes the crown, and here you see an X-ray after 1 year and after 3 years. And because we really want to report on this technique, because also with severely resorbed sockets, the results were amazing. So we published last year a pilot study together with my colleague Lodewijk Groeneman and Ist van Urban, and it was published in the IGPRD. And we only included patients with the tooth which was going to be extracted with a lot of bone loss, more than 50%. And if you're interested, I would refer you, as already Russ stated, the webinar from last year. You can see it on the Osteogenics YouTube channel, and it also shows on a model with a video how this technique works. So because we have been using this membrane, this dense PTFE membrane for more than 15 years, we were building up our experience with the closed GBR and also with the open GBR. And through time, when we performed the closed GBR and we got an exposure, we start looking differently at it because we had the experience of the open GBR. And knowing also from research that with the open GBR, although the membrane is exposed, you still get a lot of bone growth underneath. So that's why the article. And what's the article all about? Well, first we have a look. We made up 3 classes. And here you already see that the first class is a membrane exposure without purulent exudate. And we also pay attention if the membrane edges are covered or not by tissue. And that's the distinctive difference with other classifications. They don't pay attention to that. But we thought it was of crucial importance because if the membrane edge is not covered, especially in an early stage, there's an entry for bacteria. The second one class is the membrane exposure with purulent exudate. And the third one, there is no exposure, but there's a fistula and swelling. And also in the article, I made a flow chart by the steps which you could take to deal with it. And as said earlier, we got feedback, positive feedback, but there was also one colleague who said, well, I read your article and it's far too difficult. And in a way, I was a little bit, to be frankly, I was a little bit annoyed or, in a way, a little bit angry, like, well, it is clear. I mean, what's he talking about? So I discussed it with my colleague, Lodewijk Grundeman. He says, well, you're really into this classification. You're making these flow charts. For you, it's maybe clear. But he says, well, that colleague has a point. So I thought, why not make it even easier for colleagues around the world to use it? And then Osteogenics made drawings, figures of every exposure class or complication class. And I made then also different steps you have to make. And this QR code you can scan, and then you get this summary classification sheet or summary management sheet. And I will show this QR code at the end of the presentation again. So let's look at details because these figures make it more easy. Here we see all the possibilities when there is no purulent exudate. So on the upper left, you see there is class 1. It is the membrane edge is not covered, while the other ones the edge is not covered. I mean, for the 1A it's covered, but the others it's not covered. And then you have to look underneath the membrane, what kind of tissue is visible? Is it immature or is it mature? Well, if we move then to the other ones, the class 2, there is an exposure with purulent exudate, then you have to take it out immediately. And with the class 3, there is no exposure, but there is a fistula or swelling. And then we proposed to give first 1 week antibiotics and then take out the membrane. And of course, these classes in the beginning, you have to look what can I do for best. So I'll illustrate them with some cases. Like this one. Here we see a patient on the left with a lot of bone loss around a lateral incisor. And if you look at the cone beam, you see that the bone defect goes to the palatal. And in these cases, we first take out the tooth, let it heal, and then in the middle and also on the right, you see that after 2 months, there is a collapse of the tissue. We open up the tissues, we apply the bone graft and also the titanium reinforced membrane, and we close the tissues, as you can see on the lower right. And healing went uneventually, but then after 26 days, we got an exposure. And then I would say, don't panic, just use the management summary sheet. We see an exposure. The edges are covered and we see no purulent exudate. So we go to our classification. And then we can see that because the edges are covered, we have a 1A clinical classification. So we leave it in, and then after 6 to 12 weeks, we can take out the membrane. Why? Because the osteoid matrix in the meantime is maturing. But you see also underneath this, and it is also in the document you can scan at the end of this presentation, that if there's loose particle visible, if you take out the membrane, you have to easily scratch them away. And then you can cover the site with a collagen membrane if indicated, if the osteoid matrix is quite immature, and you can close the tissue if needed. But if you take out the membrane and you don't see any loose particles, you don't go for primary closure, as I'll show you in this case. We monitor it. Membrane removal in this case was after 10 days. The exposure increased a little. Then you take out the membrane, and here we see a very nice, regenerated ridge. The width is good. The tissues are still immature. They have to mature, of course. But here you see on the lower right that we didn't go for primary closure because the osteoid matrix was well, there were no loose particles, and it will heal by secondary healing. As we know that it takes about 4 weeks for epithelialization to occur, shown as by the Hoffman study. Also a positive side effect, if you don't go for primary closure in this case, you're not moving the mucogingival line coronally. Of course, we let it heal. And then 4 months after membrane removal, here you see then the ridge. We could place the implant, and on the right you see the baseline before. And here we see before and after. So yes, we got a complication, but we managed it well using this summary sheet. So instead of colleagues in the past taking it out immediately, no, we want to keep this barrier function alive and being in control of the barrier function, letting in the meantime the osteoid matrix mature. Another case, patient was referred. Her dental history was that there was a cuspid impacted, and they tried orthodontically to get it out, but it was ankylosed. So they took it out, and then the tissues healed, and the patient was referred to us. So here we see the tissues are healed. We open up, and of course, we see a lot of bone loss due to taken out of the impacted cuspid earlier. We're going to do the same GBR technique as we do in daily practice. Apply the bone graft, apply the dense PTFE titanium reinforced membrane. I would say, what else? And then close the tissues. And the healing was uneventually. But after 2 months, we got an exposure. Okay, but now we're going to use the summary management sheet again. We got an exposure, yes. Edges are covered, yes. Purulent exudate, no. So we go to the classification and we see it's a 1A. But we're going to follow it up through time on a 1 to 2 weekly based. And then we continue, and 5 weeks later, we saw this. The edge now being exposed. But we see underneath the membrane that there is tissue around. So in this way, we take out then the membrane because it had some time of healing. And in the meantime, it's important to state that the edge was now visible, thus it changed into a class 1C. So a complication can move from 1A to, for example, 1C. And then you have to take different steps. We take it out. Here we see when we take it out, the membrane. And We covered, in this case, the immature osteoid matrix with a collagen membrane and closed up. And here we see 3 months later, we see the X-ray and we could place the implant. And here we see then before and after crown placement. In the clinical view, 1.5 years later. And again, yes, we had a complication. But again, apply the classification and also take the right steps, and we end up with an acceptable result, if you ask me. The following case, I always introduce that it's from the category, don't try this at home. But it really illustrates well the potential of this membrane and also illustrates well what is the result if a complication does occur. Let me illustrate it. It's a case treated more than a decade ago by my colleague Lodewijk Groendeman, and he took out 2 incisors. Then he placed an implant at the central incisor position, applied the bone graft and also a titanium reinforced dense PTFE membrane, and covered it with a connective tissue graft. So a lot of things at the same time. So tricky in a way. And the healing went very well. But then after 2 months, there was a swelling and fistula. And we thought, this is too much. We pushed the limits too far for this material. But first, we said, look at our clinical classification. It's a class 3, fistula and swelling. And so we gave the patient antibiotics for 1 week and then took out the membrane. And when we took out the membrane, we saw this. And we were really amazed. We saw, well, we still see a very positive regenerative result. And maybe you're wondering, 1 minute ago, or the last slide, I told you that my colleague placed an implant at the central incisor. Well, it's still there is, but the bone has totally grown over it. But this is 2 months after GBR. It's immature, regenerative tissue, so let it heal. That's why 4 months after removal of the membrane, my colleague opens up the tissue and has to drill away bone. I repeat, he has to drill away bone to get to the cover screw because it was still totally grown over it. And here we see then the prosthetic result. Complication, yeah, but we could deal with it. And then it's nice to share an interesting discussion I had with my colleague Lodewijk Groendeman, because he says, well, you're busy with this complication rate and complication healing. And he says, why are you calling it a complication? He says, if I have such a situation, I know what to do and I know what the result will be. So is it really a complication? You can discuss that, of course. If you have a swelling or fistula in the beginning of the GBR, shortly after GBR procedure, yes, you can lose still a lot of bone. But in these 15 years we have been using this technique, this swelling or a fistula didn't occur within the first month or 2 months. So by taking the right surgical measures, you can also prevent a lot. And of course, we noticed that our learning curve reduced the exposure rate through the time. But if you like it or not, if you do GBR from time to time, you will have an exposure. And it's nice to know how to deal with it. So these cases really show what we have learned from the open GBR in the past, applying it when a complication, healing complication, did occur around the closed GBR, and also being able to have very nice results. So we come to the conclusions. apply these steps, this clinical classification, it will help you in your daily practice by taking the right measures. And also, yeah, GBR is not easy. It takes experience and also skills. So if needed, get trained, go to hands-on courses, and you will notice the effect on your learning curve and also reduce your complication rate. And by doing so, you will also build up your confidence when you're performing these GBR procedures. And of course, then it's nice to know that in the back of your mind, you'll know you have that useful summary management sheet at your disposal in the rare case a complication does occur. I thank you for your attention. Here you see the QR code you can scan, and then you see the document so you can print it out and use it in your daily practice. And I'm sure it will help you a lot, and that's our aim. I thank you.
Thank you, Dr. Vroom. Very well done. We do have a few questions that have come in, and while I'm asking Dr. Vroom these questions, feel free to click that Q&A button and submit your question so we can get it answered. First question came, so the case where you show that you're using a titanium reinforced PTFE membrane exposed, you know, it was that the author says, I thought when you use titanium reinforced PTFE membranes, you needed to gain primary closure. Is that the case? If it's not the case, do you have a decision tree for when you might choose to leave a membrane exposed versus get primary closure over it?
Yeah, well, the separation we did to distinctive between the indications, we leave a membrane open if it's an open GBR, meaning we extract the tooth and then directly cover the extraction socket with the membrane. In all cases where a tooth is already taken out and the tissues have already healed and be closed, then we open up the tissues, we apply the bone graft and the membrane, and we always close it because then you get the best healing. And the titanium reinforced after extraction, which is also described in that pilot study, that's to our knowledge the first article reports on using titanium reinforced, is because the rationale behind it is that we have a very stable scaffold, and the clinical handling, especially placing the membrane underneath the papilla of the neighboring teeth, is so much easier when you use this titanium reinforced membrane. But for the colleague who asked this question, I would refer him also to watch the webinar from last year, which really illustrates well the indication of open GBR.
Good. And I think just to kind of, I guess, summarize that, and you can agree or provide feedback here, Dr. Vroom, but whether whether there is titanium reinforcement in the membrane or not, that is not an indicator of whether it should be you should gain primary closure. It's all about the protocol being used and the defect that you're grafting. It's not is there titanium reinforcement or is there not. What you just said is that if you're extracting the tooth, immediately grafting the site and using a PTFE membrane, regardless of whether it has titanium reinforcement in it, a lot of times you're able to leave those exposed and do open GBR. But whenever you're grafting a site that has the tooth has been removed for a period of time, going back in, more of a what I would say a ridge augmentation, horizontal or vertical. At that time, it's always a very good idea to obtain and maintain primary closure.
Yeah, I totally agree. You said it well, Russ.
Okay. In the class 2 and 3 complications that you or exposure that you described, would you remove the membrane and the bone, or just the membrane?
Well, if you look at if the participant has scanned the QR code, they have the document. If you look at the composition of the osteoid matrix, so if there are a lot of loose particles which are not integrated in tissues, you gently scrap them away. But you're leaving the rest of the osteoid matrix in position, so don't scratch it away. It's a kind of knowledge we got from the open GBR, so after extraction, that sometimes when you apply this technique, you maybe have overfilled the alveolus a little bit, so then some particles are not incorporated well into tissue, so you just have to scratch them away. You get a little bleeding and it will heal. So that's the same with this class 2, which the question is about, that you take it out, and also with the class 3. But with these class 3, with this swelling, we saw fantastic still regenerative tissue. But we through all these years we have been using it, this swelling, it was maybe in 1 to 2% of the cases, so very limited. And then it was maybe at 2 months or something, or 3. And then in the meantime, the tissue had a lot of time to heal.
Great. When you remove the PTFE membrane, do you ever place a collagen membrane over the site at that time?
Yeah, that's a good question. You have to look at the composition of the osteoid matrix, as you shown in the last case of don't try this at home case. You saw that it was so solid already and well shaped. I'm not gonna apply then a collagen membrane. Well, if it's more immature, then you need a barrier function for to extend the barrier function, so you can place a collagen membrane on it. The whole difficulty, of course, with this classification, and it's also what we got as feedback from the editors of the journal, is that a lot of it is based on practice experience, clinical experience through these 15 years. And it's very difficult to do research on it because you never can predict a complication.
Great. Along those lines, and I think it's going to be very case dependent, but if you do place collagen membrane in these situations, in these class 2 or class 3 complications, do you have a general recommendation on how long you would wait to re-enter the area for implant placement?
Um, Yeah, well, it's always, I mean, colleagues, Dr. Grunder from Switzerland states it's very well always, I find, with GBR procedures, give it time and fixation. So give it time to heal. Of course, it matters how large the defect is. I always have as a rule of thumb that bone grows with 1 millimeter a month. So if you have to build up 6 millimeters, give it at least 6, 7 month healing time to really mature.
Great. Um, in the cases with connective tissue grafts, were they placed over the dense PTFE membranes?
Yeah. Yeah, but again, it's don't try this as home case. It was really pushing the limits. We don't do that on a regular base. No, I mean it's better to have the tissues closed, and then if you remove the membrane, if you have no complications, let the tissue heal. But also then at that time you can place your connective tissue graft. If it's a complication, I would just first let it heal and then later on build up the tissues.
Um, some questions about managing patients, maybe some post-op instructions. Have one specific question. Do you recommend a patient cleans the area with chlorhexidine after surgery or with
Yeah.
a cotton tipped applicator?
Yeah. No, that's what we described also in the article, that rinsing or with an you call it, I think, a cotton plug.
Yeah, yeah.
You can also, you can put it on to get some cleaning, but very gently, of course, because you don't want the patients to move the membrane all around. But of course, to keep it clean and no hard cleaning is important. But you have to keep it clean. So yeah, chlorhexidine for a long time. Yeah.
A couple questions, and we've kind of hinted around it, but if you're when you're extracting a tooth, what are you looking for to decide if you're going to do open or closed GBR? Understanding, like, I guess at that point in time, how do you decide if you want to go ahead and graft the site with the open GBR
Yeah.
protocol, or is there something some parameters that you're looking that might make you decide you're going to close the site and come back in later and do a closed GBR protocol?
Yeah, it's a good question. I have to laugh a little bit because we get it a lot often during the hands-on or lectures. Yeah, it's in a way it's a topic for a whole webinar, Russ. But to answer shortly, uh, if especially on the lateral sides, if there are tons of pus coming out, we don't do the open GBR. But through the time, we were so surprised about the results we got, and that's why we published a pilot study to really 10 patients with severely resorbed sockets, or totally blown out buccal walls, or 4 patients had a fistula, and still the healing went well. It was incredible. So what are the limits? We don't really know so far, but if there are tons of pus, I wouldn't do it. And especially in the frontal area, we got the experience that if you, for example, have an alveolar ridge of about 6 millimeters, implant placement is going to be difficult. So yeah, why do then the open GBR? Why not take it out and let it heal? For example, my first case was a large defect through and through. Yeah, then we take out the tooth first, let the tissues heal, because we have to restore so much bone. Then it's better than after 3 months go back in and do the GBR.
Great. We will end it on this one. It's an interesting question. Just basically, do you have any tips for the clinicians on the call to pay special attention to, tips to avoid just help avoid infection when performing these GBR procedures? The question
Yeah.
says sometimes even though they respect all the steps to successful GBR, the patient still presents with an infection.
Yeah. Yeah, well, it's of course good to know that if we, for example, see the results of Istvan Urban, I mean, one of the top clinicians, he reports infection rate of 1 to 3%, if I'm right. So everyone has got an infection from time to time. If I train colleagues, I notice that uh, we pay a lot of attention to not get saliva in the area. I mean, the GBR, if you look it from, as I call it, a helicopter view from away, it's orthopedic surgery we are doing in one of the most dirtiest part of the human body, the mouth. So it's really tempting procedures we were performing. So saliva, not around. First, before rinsing with chlorhexidine, have a periodontal, very healthy patient who has a lot of has a good oral hygiene. And also, if they're still in the area sites, you see some plaque before you start making your incision, take it out or remove it with a scaler to get all those plaque out. But you need a very motivated and also patient, but also with a very periodontal healthy mouth to have the best chance of not getting infection. But if you like it or not, you're gonna have infection. And also an dehiscence. You can try your best, but of course it should be low numbers of exposure rates.
Great. I said that was the last question, but one more just to follow up on that, and then we will end it. How do you handle the topic of patients that smoke?
Yeah. What I find interesting, if you look at the study of Hoffman, who in 2008 reported on the cytoplast technique after extraction, so the open GBR, including about 260 teeth. They included patients with smoking up to 10. They included up to 10 and still saw very nice results. But that is the open GBR. With the closed GBR, it's so technique sensitive. So I exclude patients who smoke. It's the same as surgeons who do aesthetic surgery. Else, they also not include patients who smoke. It's so important that you don't have the smoke on it. And by the way,
Okay.
what sometimes I say to patients when they have these closed GBRs, say really cherish the site and be very gently with it. And I also make the comparison that on a broken leg, you're also not going to walk. Well, this is the same. And that's very clear for patient. Make it exaggerate a little bit. Yeah.
Great. Well, thank you, Dr. Vroom. Always a pleasure. Very well done. Really appreciate you taking the time to present to us and to the audience today. For everybody in the audience, please be on the lookout for the survey email that will be coming out here in the next probably 15 to 20 minutes. We'll hit your inbox. Once you fill that out, that will prompt us to send you your CE certificate. Also, this webinar, we will upload it to our YouTube channel. Generally takes about 48 hours to get that done, but it will be up on our YouTube channel here in the next few days. So please feel free to visit the channel and also share with your colleagues that weren't able to make it so they can log in and learn alongside us. With that, that will conclude today's webinar. Thank you, everybody.
Thank you.